great response to True Wealth's Diabetes Management series covering nutrition and diet, Dr. Anil Bhoraskar systematically presents the treatment options for managing diabetes. Dr. Anil Bhoraskar has completed his MD from Grant Medical College, Mumbai in 1980 and has been recently awarded the Fellowship of Royal College of London. In his 4 decades of diabetes practice, he has treated over lakhs of patients with diligence. Treatment of diabetes being Dr. Anil Bhoraskar's forte, this episode is a must-watch to understand what drugs can be appropriate in management of diabetes. We are fortunate to be able to pick pearls of wisdom from this huge personality. True Wealth is most proud to bring to you this episode as True Wealth believes in separating science from hype and bringing authentic nutrition and healthcare information to your fingertips. Please remember, this episode presents the doctor's experience for better understanding and management of the disease. However, no treatment should be taken without proper advice from a physician or healthcare professional. You can feel free to reach out to True Wealth for taking advice from these stalwart doctors and nutrition experts. Over to Dr. Anil Bhoraskar.
Our next episode, which I have been forced to discuss by many of people who saw my program on YouTube. They said, Doctor, there are so many new drugs which have come in the market, and at times we are really confused because from doctor to doctor or from institution to institution, people keep on changing the brands or the type of drugs. So I thought I'll just give some total of some of the drugs which are traditionally used and have been used for years together. But the first principle which I must tell you, that all the new drugs are not the best and old drugs are not to be condemned. They are as good, they are as effective, they are still working on human body. So one has to be very judicious in understanding what is the mechanism of action of all the drugs. I have tried to simplify this. So essentially, the drugs are divided into 2 categories. One is the orally effective drugs, and the second drugs or therapies are injectables. The orally effective drugs traditionally are 3: metformin, sulfonylureas, and alpha glucosidase inhibitor. They have been used for years together very successfully. Many type 2 diabetics have been treated very well. They have been able to manage their diabetes and avoided complications for 20-25 years. I know some people who have used metformin and sulfonylurea for last 25 years and they have not developed a complication. And the HbA1c, we never did it first earlier. Now HbA1c started doing it last 5-6 years. And the HbA1c is also not bad. So these drugs are good, they are easily available, and the most important, they are cheap. They do not cause burden on the patient's pocket and reasonably safe. Patients tolerate them well, and they are, if you say the whole consensus, in spite of a lot of new trials and a lot of new promotional activities of many pharma companies, the drug of choice and drug which is sold still the most in our country is metformin and sulfonylurea. So it's an age-old drug, useful. But what was the need for finding new drugs? Because these drugs had some shortcomings. And what is the first shortcoming of sulfonylurea? Sulfonylurea basically is a drug which contains a sulfa molecule, and it stimulates your pancreas. So it is working on the premises that your pancreas has got some viable beta cells. The beta cells are still there, which are producing insulin. So you stimulate them a little bit and squeeze more insulin out of that. That is the basic funda of these drugs. We call them insulin secretagogues. They make pancreas produce more insulin, and in patients who have marginal insulin deficiency, these drugs are useful. They produce more insulin and can bring down the blood sugar. Now, what is the problem with these drugs? Number one, sulfonylurea can produce little more action than what it's supposed to do. What is that more action? More action, it produces more insulin than required. It doesn't produce insulin like in normal body. The body produces insulin as the amount of food enters the liver. It produces the exact amount of insulin which is required for that. The body never produces more insulin. But sulfonylurea does not have that feedback system. So it produces insulin in a large amount, and sometimes the food may not be as much, and the patient may have more insulin, and therefore it produces hypoglycemia, which is definitely more dangerous than the disease. So hypoglycemia was one side effect of sulfonylurea. Second thing, with sulfonylurea, as the insulin is being produced more, the person eats more. He feels well and he eats more. His sugar is under control. All the time the blood sugar which was being lost in the urine along with the water, that is stopped. So the guy who is on sulfonylurea puts on 4 to 5 kilos of weight. Now that is not liked by many type 2 diabetics who are basically come for obesity. So weight gain and hypoglycemia are the two major side effects or unwanted effects of sulfonylurea. So they thought that we must find out something else. So there was a lot of research recently, and in last 10-15 years there have been a group of drugs, and they found out that there is something known as a system in the body, incretin system, which is in response to food, the gut produces a hormone, and that is known as GLP-1, and that produces improved action of insulin on the foodstuff, and they are the DPP-4 inhibitors. We call them DPP-4 inhibitors, and they came into market and made a lot of changes because people wanted to know after metformin and after sulfonylurea what to give. The only option of insulin. People did not want insulin. So these drugs came in that small area where people needed a third drug, and they were drugs like sitagliptin, vildagliptin, saxagliptin, and levogliptin. Now these gliptins are DPP-4 inhibitors. There is one enzyme in the body known as DPP-4 which is inhibited by this, and it improves the action of your endogenous insulin and reduces blood sugar as well as HbA1c, and been found very useful. They do not produce hypoglycemia. That's one great advantage of this drug. And therefore combining this drug with the existing sulfonylurea metformin became a practice in many patients, and they could delay the use of insulin by 2 to 3 or 4 years, brought down their weight, brought down their other enzymes which were detrimental, and also help to bring down HbA1c. So they became very popular, and they are still very popular. So DPP-4 inhibitors, we have about 4 of them already there in the market. Saxagliptin, linagliptin, levogliptin, then drugs like sitagliptin, Their names are very interesting. They are all given on a feminine names, and easy for doctors to remember. But they are definitely good drugs. Some of them were notorious. They were worried that they could produce pancreatitis, but we have not seen many cases of these drugs producing pancreatitis, nausea, vomiting, or any side effects, or severe hypoglycemia. One great advantage of this drug that it doesn't produce hypoglycemia. Then came the revolutionary drugs, which are known as SGLT2 inhibitors, and they cause a lot of change in the therapy. And these SGLT2 inhibitors predominantly used were drugs like empagliflozin or gliflozins essentially, out of which canagliflozin, then EMPA, then the new generation gliflozin being used. Now, advantage of these gliflozins, SGLT2 inhibitors. One, it brings down the blood sugar. Second, it also acts on water retention. It causes diuresis. It causes volume contraction. It reduces the cardiac output and brings down the blood pressure. And most important and most rewarding experience with gliflozins is causes weight reduction. People want weight reduction, 5 to 6 kilos weight loss. And this drug now is used very, very frequently by the cardiologist because they see the benefit of this. So these 4 drugs which have come up in the market recently are very, very encouraging. We probably started with dapagliflozin, then came Cana, then it came with empagliflozin, and there are multiple trials. Nowadays what they do, what is known as CV outcome trials. What is the CV outcome trials? Formerly there was a drug known as glitazones, excellent drug, rosiglitazone. This drug brought down the blood sugar in many patients, but it produced cardiac abnormalities, and America banned that drug. But its other cousin, pioglitazone, is still on, and it's an excellent drug for insulin resistance. India, we still use pioglitazone. So after this episode of multiple cardiac abnormalities faced by this drug, there is something known as CV outcome trials, that is cardiovascular outcome studies done on thousands of patients to see the safety of these drugs. Now the issue is that the drug may be effective, it brings down the sugar, but it must not have any cardiac abnormalities, either in form of failure or cardiac attacks, and therefore CV safety is a primary event in managing any new drug, and therefore you must have CV safety reports. All these drugs, gliflozins, have passed the test of CV safety trials where they spent millions of dollars on that for the CV safety, and it has proven that these drugs are safe to be used. Now, the only problem with these gliflozins is the passing lot of sugar in the urine. The basic mechanism of SGLT2 inhibitor, it is a glucose transport inhibitor, sodium glucose transporter inhibitor. Therefore, what it does at the kidney level, it throws away 180 grams of sugar in the urine. So it's very strange that the very symptom of diabetes, that is passing sugar in the urine, has now become a treatment. That you throw 180 grams of glucose in the urine, thereby causing loss of sugar, and along with the urine you lose water because the sugar has to pass off with the equal amount of solute. So they lose water and they lose sugar. Luckily, they don't lose sodium. The sodium is not lost. So there is no loss of sodium, but loss of sugar and loss of water. Now, what happens when there is so much of sugar passing in the urine? Obviously, sugar is a substance which will invite germs. And therefore, when the urine passage passes so much of sugar in a day, it becomes vulnerable to infection, particularly in females. And it can cause severe urinary tract infection if the woman does not follow principles of personal hygiene. These problems were seen more in the foreign countries, but not in our country so much, of causing fulminant urinary tract infections and fulminant necrotizing fasciitis and complications. Although there is a black box warning of these drugs that this can happen, and people who are vulnerable for urinary tract infection, particularly females, elderly females, should not use this drug, because this is one side effect of this. Other side effects are few, but they are not to pay so much attention. But I think the greatest side effect, in my opinion, of this drug is they are costly. Any drug which is beyond the means of a common man on a long-term basis. Some of the drugs are almost 42 rupees a day. That becomes quite a lot of expenditure. This will be solved if more number of people use this drug and the manufacturers bring down the price because of the volume. I think those days are still yet to come, because some of them are still patented formulation and therefore they are expensive.